improving satisfactorily. In that case, I would like to consider that if it is tuberculosis, in spite of the good treatment, good compliance, why not the child is showing the improvement? Various aspects you can put forward. You can say that looking at this even, the particular tuberculosis contact neighbor, already one person died, another somehow suffering from the disease. I would like to consider that is it really the infection source is from the neighbor, which is more likely. And as all of us know, I would like to give the thought for this multi-drug resistant tuberculosis. Before that, I would like to check for the severe acute malnutrition, which is very common, maybe the common factor for not allowing the good response. Associated comorbidity, HIV is very common, and even death may be of neighbor due to the similar disease that I would like to check. Or even not necessarily always due to tuberculosis, whether was it confirmed in expert or every information we don't have. And therefore, differential diagnosis we'll have to consider. Maybe even some malignancy and your secondaries at the elbow, and even the secondaries can occur in these hands also. So that is not, I will say, strong possibility, but I will say remote possibility. If I fail to confirm for the tuberculosis, I will have to consider. Of course, with the tuberculosis, primary immunodeficiency and other things should be kept in mind. So the point is, whatever the information we have, our explanation should be related to that information only. Anyway, but it was really good. Before we go further for the examination, any comments from Dr. Sushant or Madam?
Can I make a point, sir?
Yes, sir, certainly. Please.
No, that she has mentioned subacute pancreatitis as a first possibility or at the top in the list. But of course, bone involvement is not the thing. And of course, invariably there will be vomiting and severe pain, which will be intolerable during that particular period. So I think it should be lower in the list. That's what I felt.
Absolutely.
Okay.
So, sir has very well summarized. I just want to add one thing. So, when we are giving an impression on history, okay, always take everything together. When we analyzed, we took it separately. Abdomen was separate, then your elbow was there, and then to our help, we had a past history. So, when you correlate everything, then you frame a diagnosis. So, that is what Srinivasan sir also telling. Just pancreatitis, everything cannot be explained. Okay, so that is why what sir said is and we have a history of contact, the child is already on treatment, so that becomes the first diagnosis. Tuberculosis. Second, definitely we have a systemic illness. We can, because tuberculosis was not confirmed, we don't have details whether it was an expert confirmed diagnosis. So any systemic illness like a malignancy which is presenting with metastasis, so that is what I want to add.
Absolutely. I think many times, Dr. Sushant, whenever talking to these students, how I explain them, the same thing what you say, that when we are teaching the drawing to children, what we do, that make the one circle, then the bigger one at the middle, and third one at the last. And then we say that join these circles. Then we say, oh, it is the face, this is the trunk, and this is the tail or something. So that means here, whatever the information we have, analyze it properly, try to derive some inference or interpretation, and then put all the points together. That what does it indicate? And that will, I'm sure, that will create some impression that, oh, this is this of the disease, chronic disease, acute disease, something like that. And then you can consider common, and then the less common at the end, rare. And I'm sure with that process, we'll be able to reach the diagnosis. Thank you very much. I think should we go for examination, because we have taken sufficient time the whole day only. Yeah, please.
Go ahead with the examination. Anjali, you have to unmute also.
Moving to examination, anthropometry. The patient is underweight with normal height and head circumference. BMI shows that the patient is having severe thinness, and Tanner staging is stage 1. On general examination, patient is comfortably lying on the bed, oriented to time, place, person. On examination, she is afebrile. Heart rate is 88 per minute with normal rate, rhythm, volume, no delay. Central pulsation and peripheral pulsation is well felt. Respiratory rate is 36 per minute, which is abdominothoracic and which is regular in rhythm. BP is 5 to 58 centi in lying down position taken on the right arm. Some pallor is present. No icterus, edema, cyanosis or clubbing is noted. Cervical lymphadenopathy is present, but it is not significant. On head-to-toe examination of the patient, there is characteristic look of the patient with frontal bossing. BCG scar is noted over the left shoulder. Abdomen is distended and shiny, and umbilicus is everted. Distended veins are present over the abdomen. No peripheral stigmata of TB is noted. The spine is normal. Crazy pavement dermatitis is noted over upper and lower limbs. Left foot, as seen in the picture, shows oligodactyly with camptodactyly. Joint description is done in detail later.
So Divi, you
Yes.
said the spine is normal in this photograph and in the previous slide. Can you see something? What is the posture of the child?
Sir, actually, due to the abdominal
Yes.
distension, there is a bit of a lordosis which has occurred.
Okay, and can you see the level of the shoulders, the right and the left? Just see in the previous slide also, when there is a frontal view which you see in the previous slide, the slide.
I think you can go to the previous slide, what sir wants.
There's slightly drooping on the right side.
Yes. Okay, you can see now the right shoulder is drooping as
So
compared to the
drooping,
left.
Yeah.
What could be the reasons for that of the drooping of the shoulder?
Are you able to go to the previous slide, Dr. Anjali?
To the back slide.
It is seen
Yeah, that's all.
yeah, this photo. So right is definitely drooping, right? So what could be the reasons of drooping of unilateral shoulder?
Sir,
Could be collapse.
Fibrosis of the lung of the same side.
sir, I think it is maybe due to the weight of the dressing. So.
Yeah, so one is
Hmm.
definitely the lung which is there. There is a collapse or fibrosis, something.
Hmm.
And even if there is something going wrong in the spine or the vertebra, okay,
Yes, sir.
the
It can
patient will be there. So especially in this patient, when we are having multiple sites involved, you had lung, then you had abdomen, then you had elbow. So that is a very important finding, and that should come in your examination because it is seen very prominently. I mean, in the photo it is seen so prominently, so when you are seeing it will be more prominent.
Okay, sir. Now moving to the joint examination, the right elbow joint, there is 10 into 5 centimeter ill-defined swelling present over the elbow that is obscuring the olecranon process. No redness or tenderness. Redness is noted, tenderness is present. In the right index finger, 2 to 3 centimeter ill-defined swelling is noted over the middle phalanx with no tenderness or redness noted. No restriction of the movement at distal and proximal interphalangeal joint is noted. No other joint involvement is also noted. Moving to PGAS, gait is unaffected for the patient. Arms, right elbow joint, as we can see, is in semi-flex position with restriction of the extension. Legs and spine are unaffected. Now moving to the systemic examination per abdomen. On inspection, the shape of the abdomen is distended and have a shiny appearance. Skin shows dilated veins that are non-tortuous. Movement with respiration is normal. Umbilicus is slightly everted. No visible pulsations are seen. Hernial orifices and external genitalia are normal. On leg raising test, the swelling disappears. This is the view from the foot end of the patient.
And this is a.
This is the video that.
Okay.
On palpation, a palpable mass is noted over the epigastrium and extending to the left hypochondriac region. It is about 15 into 15 centimeter in size, which is tender and hard. Upper margin is undefined. Fingers cannot be insinuated below the subcostal margin. Notching is absent and it is a non-ballotable mass. Liver is just palpable 2 centimeters from the right costal margin and it is smooth, soft and non-tender. Spleen is palpable, but cannot be separated from the swelling, and it is non-tender firm, but lower border is felt at about 5 centimeters from the left costal margin. Kidney is not palpable. On percussion, no fluid thrill or shifting dullness or puddle sign is noted. Dull note is present in the epigastrium and the right hypochondriac region, that is mainly over the mass, and tympanic note is present over the rest of the abdomen. On auscultation, bowel sounds are present and no bruit is noted. And moving on to the other systems, cardiovascular system, respiratory system, and CNS system, on detailed examination, no abnormalities are noted.
Okay, can you stop sharing?
Yes, sir.
I think I wish Dr. Sushant, can you take in details of the examination with the students?
Yeah.
Because I think very interesting in the general examination as well as in the systemic.
So in systemic examination, general examination we discuss, in systemic examination, especially in the abdomen, right? So we have two findings. One, there is a prominent mass in the upper part, right? And then if you see from the foot end, there is also swelling of the abdomen. So how can you, I mean, explain this? And then you have described the mass also. It is in the left epigastrium, then it is hard, it is tender, it is not mobile, right? So how can we explain this? What it could be, and what could be the generalized swelling?
I think let even other students give their comment. Please answer sir's question. Dr. Shweta, Dr. Datta.
Dr. Datta, you can answer that.
Yeah. Even Dr. Divya, I think she's also putting the comments, good comments on the chat box. Can you take a question from sir? Dr. Datta, I think you are on the screen. So come on, rather than putting on the...
Unmute.
Yeah, unmute.
Are you
Even
all
may,
in the ward?
yeah, you even may not keep the video on, but at least you can unmute yourself and try to answer. Come on. I think that is also part of the teaching that make the student to speak. We'll have to keep the patience, but I think we'll keep the patience, but they
Yes.
should
Sir,
speak.
it may
Appu and
be
Datta.
mass of intraperitoneal origin,
Right.
which is moves with respiration and which is not moving, which is tender and showing left-sided swelling and epigastrium. So in epigastrium there is a stomach is there, and in the left-sided spleen, maybe the swelling of spleen is there. Splenomegaly is there.
Shant sir's question was, there is one swelling and foot end. If you look, the whole abdomen is looking distended. So how do you explain and why is there a distension of the abdomen? Swelling, it's okay. It is higher up in the epigastric and towards the left. What is the word he wants? When does the abdomen gets distended like this?
Ma'am, if there is a fluid accumulation is there, so
So,
ascites, maybe
okay,
ascites is there.
okay.
So that photo shows clearly, the skin is so shiny, it is tense, the
Yes,
umbilicus is
yes,
everted,
yes,
right?
yes, sir.
But just one thing I would like to remind, she has mentioned in the findings that no evidence of fluid, because she said no septic dull node, not even fluid. That means not any amount of fluid is there. That is her finding.
Sir,
So
if obstruction is there, any gastrointestinal obstruction is there, so if fluid is not there, but gaseous distension may be there.
okay. So that is one explanation what he's
So
considering.
when you talk about obstruction, which bowel obstruction will present with abdominal distension more prominently? Whether it is a small bowel or whether it is a large bowel?
Sir, central abdominal distension showing the small bowel obstruction.
Okay.
In peripheral, lower gastrointestinal tract obstruction. Mostly the whole abdomen is distended.
I think your comment is good. Now, if you see that what is shown in the picture, from that, what is your comment? Large intestine or small intestine is likely involved? I think that
Sir,
is the
mostly
question from sir.
small intestine is there because central abdomen is more prominent than peripheral.
Dr. Sushant, you can take it further, please.
Yeah. So what are the other findings what we have mentioned? One is abdominal distension, it is diffuse, and there is a mass, right? Anything else
The liver
in
and
the
the
abdominal
spleen are
cavity?
also palpable.
Liver is palpable and the
Liver is
spleen is also liver is
And there is
spleen
a
is
dull
enlarged.
note over the mass.
Mass.
mass. Okay, so it is a hepatosplenomegaly which is there, and the child has pallor. Anything else in the abdomen examination? No.
No. Sir, it mainly shows a focal, matlab one side is enlarged and there is no fluid is noted, especially no other signs are negative. So it mainly shows some organ enlargement is there.
One is organ enlargement, right? So liver is enlarged, spleen is enlarged. We have both, and then you have certain thing which is sitting in between those two, and it is palpable, right?
Yes.
What it could be? That is what we are getting
Yes,
into.
sir.
So what? So I'll put it in other ways. Okay, whatever is the pathology. Suppose we're thinking of TB or we're thinking of metastasis or something, malignancy. What happens? What is which organ or structure inside the abdomen is mobile and tries to cover up? We have
Omentum.
momentum. So even if you see, whenever we talk about a ileocecal TB or when you talk about something else lesion, what happens is whenever there is inflammation, okay, the momentum tries to wall off the inflammation.
Yes, sir.
Okay, and in that process, when the momentum is also involved, it also gets inflamed, and then you get something a mass kind of a lesion, whether it is a RIF, right iliac fossa mass, or an epigastric mass, or a lumbar mass, whatever, depending upon. So probably depending upon what history we have, we can, you know. Conclude that there was something going on in that epigastric portion of the lung, okay, and the momentum has got involved into that, and it has formed a mass. Now again, one important thing what we want to remember is in the epigastrium, okay, and it is more towards the left side, right?
Yes, sir.
So what comes on the left side apart from the spleen, which is not an intra-abdominal structure? You had said it while discussion.
Kidney, just an extra period.
Not
Kidney.
an intra-abdominal. Not an intra-abdominal. The lower part of the lung, right?
Yes. Yes, sir.
You had one prominent
Yes.
thing that some tube was put,
Yes.
right?
Yes,
So was it the right side or was it the left side?
So the
sir.
tube was put
Put
through the
in
mouth.
mouth.
Acha, so that was a procedure,
Yes.
the thoracic tube.
Yes.
Okay. So again, when something is going wrong into the, I mean, in the lower part of the lung, okay, what is the pleurisy? Okay.
Yes.
Yes. Okay. And then the contiguous organ is spleen,
Yes.
right? So in that, so below the diaphragm, you have subdiaphragmatic area on the right side, on the left side. So
Yes.
any collection, if it has happened in that area,
Subdiaphragmatic.
again, it will give rise to, and the collection has no place to go because it is a closed structure. Even that can give rise to a swelling. The only thing which is going against is what is the character of the swelling, what you have mentioned on palpation? Hard.
Yes.
Okay, so there is something which is there inside. Okay, it is not just a collection or something like that. So that is how we have to think when we talk about abdominal examination.
Fine. I think I have certain questions, Dr. Anjali. Somebody
Yes, sir.
was discussing. Sorry?
Sir, they have mentioned that the swelling disappears on raising the leg. Is it what you said, Anjali and Divi?
I think they said disappears or decreases. Am I right?
Yes.
So how do you interpret it? How do you interpret it?
Which swellings disappear like this and connection between raising the leg and the swelling disappearing or becoming less prominent?
It became less prominent.
Suppose it becomes more prominent. In some other patient, it becomes more prominent. Then what it could be?
Extra peritoneal.
In the abdomen, abdominal wall muscles.
Yes.
You know what we want to differentiate by the straight leg raising test, that suppose mass or some swelling is the abdominal wall muscles, it becomes very prominent with the state raising. And if it is intra-abdominal, it becomes diffuse or it may disappear.
Less.
Now, I think I have certain questions with the previous discussion. Somebody said intestinal obstruction. What are the points favoring obstruction? I think you said there was no vomiting,
No,
right? Even you said that there is a peristalsis normal.
Yes.
There was no constipation.
no.
Right. So I think straight away from this, we can say that no point favoring
like,
the
no.
intestinal obstruction.
Yes.
What are the points already Dr. Sushant paid very appropriately? Whatever we have, we can make it positive. Yes, we can say organomegaly, that you have the evidence. And very important, I think at least no pre-fluid in the parietal cavity, that means no ascites. But then still, why there is distension of abdomen? Already discussed that, it indicates that there is some whatever the disease process. I think organ of RE system are in action. Liver is a part of RE system, spleen is RE system, omentum is also part of this RE system. And it is a body mechanism that it is trying to restrict the disease, localize the disease. And therefore, these organs are involved. And they can present in the forms of mass, even ileocecal or something. And even sometimes there will be even peritonitis also. And this type of the peritonitis will not be having the acute presentations. They can have even the mild fluid also in a case of peritonitis. That also we do not know with this clinically, but of course you can go for further workup and you may come to know. So as a whole, in short, we can come to the conclusion that in abdomen point of view, this is a disease process which is spreading and other organs are trying to make it localized. Another part of disease process, this liver and spleen and some mass has been developed and maybe the part of even the peritonitis. I think this much we can explain. Further, I think on somebody had mentioned, lordosis is very apparent to see. Explanation may be the difference. It may be the physiological pregnancy, but yes, lordosis is there. Maybe in a case of ascites, maybe in a case of really lordosis due to the spine deformity. But whatever is seen that we should mention, and always cachexia. I think some people are using this wasting. Somebody say it is even the cachexia. Somebody say it is the emaciation. So all these terminologies, I will say, are interchangeable or definitely they have some meaning. Anjali or Divsi, what is your idea? When you will is the wasting, when you will is the emaciation, and when you will say it is cachexia. What they indicate, what I mean to first, when you will say it is wasting or emaciation and cachexia, first that we should be able to identify, and then what they indicate.
Sir, cachexia means like as a part of a chronic process, the patient is malnourished.
Okay. And what is emaciation? And then what is wasting, I think commonly we are discussing in a case of malnutrition. In marasmus, we say it is the wasting, right?
Wasting is the loss of muscle mass that we commonly refer to as wasting.
Okay. Wasting usually, we use it the under 5 to describe the very specific variety of malnutrition, where probably there is a great loss of fat and to some extent muscles. Wasting, emaciation, usually we say when the mainly fat is lost. Many times I think some of your friends, you are looking emaciated. You were not emaciated initially. That means some fat is lost, weight is lost. Cachexia is very important when you are using the terminology that there is significant loss of weight, even with the loss of fat, muscles, to that extent that looking like just skin and skeletal. That is cachexia. And cachexia indicates very significant certain diseases. If chronic tuberculosis, acute malignancy, or even sometimes hyperthyroidism, that within the shortest time they appear like cachexia. So the point is, if such presentation is there of the person, you should think seriously. There's some disease is going on, whatever the disease, you may not be able to answer, but yes, extensively we should try to search. So what was my idea that when you are using this terminology, we should have the idea that exactly what you want to convey. Having this, I will say, examination findings, what will be your diagnosis? Again, put well simply, then we'll go for the investigations and we have some at least 15-20 minutes we'll utilize. Okay, she want to share, so it becomes easy. No problem.
9-year-old female child, case of drug sensitive pulmonary TB, on most probably on continuation phase with good compliance, but no improvement, and she is completely immunized with severe thinness. So my probable differentials are, it can be case of multi-drug resistant disseminated TB that involves, the primary causes may be pulmonary TB and involves GIT, that ear may be omentum and spleen, and musculoskeletal system where the patient is having arthritis and dactylitis. And it can be late onset TB iris, and it can be non-tubercular mycobacterium infection. And we also want to rule out any immunocompromised state is there. It can be acquired.
I think Dr. Devisi will go to Dr. Sushant for this terminology later on. But on initially you mentioned that the drug sensitive pulmonary tuberculosis. On which ground you are able to make this statement? What you have the points favoring to your this statement?
Sir, in the history, mother was telling like initially the patient was taking orange colored covering and it was then changed to green colored covering. So most probably she'll be taking drug sensitive regimen.
I think that is treatment point of view. It's a different story,
Okay.
right?
Um,
Anyway, and later on you say that this is a registered. What was my point? That we are contradicting ourselves.
Okay.
Or unless you say that initially, okay, it was sensitive, the registered, but we should have some very specific points to say in the history. Then probably you can make the statement, right?
So what sir is trying to say this, in the initial part when that anti-TB treatment was started before she came to you, right? A pulmonary TB. She was started from some other place, right? So was it microbiologically diagnosed? Was the expert done or was a culture done? Yes. I mean, do you have any reports or no? Was
Yes,
she a
it,
confirmed case?
it was confirmed, sir.
It was
Then
confirmed.
that is what sir is asking. So if it is
Yeah.
a confirmed case, you can write drug sensitive TB.
I
So
think
when
in that case, you may at least mention
yes,
that talk to the parents, treating person inform the parents that
yes,
it is a diagnosis and the basic drugs are working. At least
yes,
suppose if this information is provided and we are providing. We always say that early diagnosis is confirmed even from the specific test, and we have got the information that whatever the routine drugs primary we are using, these drugs are working. Some of the parents are, but you should have this information to state. Then you can say on this ground, suppose as I ask you on which ground you say pulmonary tuberculosis, what sensitive, you can say that I talked to the parents in the history and parents were knowing, but treating person informed them that your diagnosis for tuberculosis was confirmed from gastric aspirate or sputum, whatever from that examination. And even they were told that the drugs which we are starting at the very basic drugs routinely we are using and they drugs are working. Suppose if you have this information, you can say, yes, it was pulmonary tuberculosis and it was sensitive to the primary drugs. My point is we should have some points to say on which ground we are stating this point, right? So that's the point. I think regarding the late onset TB iris also, I think anyway, let us go to Dr. Sushant because he will be better person to discuss the thing. You have any investigation you can share and then directly we'll go to Dr. Sushant. I think Dr. Sushant, you can take even the investigations part also. Please.
yeah, they can
Yeah.
show the investigation.
Yeah.
So we have divided the investigations into two parts. One part is the investigations which were done in April for the initial diagnosis. And then later on, we come to investigations from our institute. So in April, May 2024, in view of persistent fever spikes with hepatosplenomegaly on their examination, the following investigations were done. Um, Fever labs with zoonotic panels were negative. CBC was suggestive of anemia. Ferritin was increased. ESR was also increased. Uh, in the Cox workup part, sputum CB-NAT was negative. Montus was negative. Chest X-ray is not available with us. ESR was 48 mm per hour. HIV was non-reactive there. And USG local neck was suggestive of necrotic lymphadenopathy. So they had done FNAC from the cervical lymph node, which was suggestive of MTB detected, RIFA sensitive. Then they did CBNAT BAL, which was MTB detected, RIFA sensitive. They had done a CT chest also, which showed area of ill-defined consolidation measuring 16 into 19 mm seen in the left hilar region. Few tiny soft tissue density nodules seen in the bilateral lung lobe, suggestive of infective etiology. Then USG A plus P was also suggestive of hepatosplenomegaly with necrotic lymph nodes. Then CCT abdo was done because USG was suggestive of hepatosplenomegaly, and there was a mass in the pancreas, hypoechoic mass. So that was suggestive of intraparenchymal pseudocyst of pancreas, hepatosplenomegaly, few non-necrotic mesenteric lymphadenopathy, suggestive of inflammatory and infective pathology. Then August May CCT abdo was repeated in their institute only. Which showed splenic abscess, chronic calcific pancreatitis, pancreatic pseudocyst, 13 into 10 mm subcapsular hemangioma in the segment 8 of the liver. Then bone marrow biopsy was also done there, which was suggestive of secondary HLH. And they had suspected their HLH and they had done the workup regarding HLH. So the triglycerides were high, 271. Ferritin was 422, LDH was 625. Fibrinogen was 322. There was anemia present. They had also done a primary immunodeficiency workup, which was negative. MRI brain was also done to rule out dissemination to the brain, which was within normal limits. So then, in short, the treatment received at outside hospital. They treated it initially like pyrexia of unknown origin. Multiple investigations were done, started on a lot of antibiotics. Patient was suspected of HLH, for which she was started on steroids. Fever spikes were still persisting, and there was new onset lymphadenopathy. So on earlier Cox workup, there was no lymphadenopathy. Later on, lymphadenopathy developed. Uh, then they did the FNAC and found out that it was TB of the lymph node. Cox workup, then they had done the BAL also after the CT chest, which was suggestive of RIFA sensitive. Hence, drug sensitive regimen of AKT was started over there. Steroids were, but the disease kept on progressing because the fever spikes over 2 months were not resolving. There was new onset fever spikes after a few days. So steroids, so they were suspecting at that point iris. Steroids were continued since fever spikes were not resolving even after starting AKT. Then the patient got discharged. Then eventually the fever spikes had resolved according to them in the hospital there, and then they discharged the child eventually. But she was off steroids when she was discharged. So she was asymptomatic for 1 month. Then again symptoms appeared, which were different this time. So the investigations which were done in our hospital were, so initially we suspected it to be MDR TB. One diagnosis was at that. So we traced the LPA of the BAL which was sent. So that came to be that came to be drug sensitive. So we continued on drug sensitive AKT. Then other investigations which were done in our hospital were the basic investigations, which were normal. In the right elbow USG, it was suggestive of osteomyelitis. These are the X-rays which were done at that point. We did a USG guided biopsy and aspiration of the right elbow swelling. The pus was sent for CBNAT, which was MTB detected and RIFA sensitive. Pus analysis was turbid brownish. TNC was 105 cells. This is the LPA of the BAL which we had traced. So Rifa resistance was not detected. Then the course in our hospital. On admission to SGH, patient BAL LPA was traced, which was MDR negative. Then right elbow USG was done, which was suggestive of osteomyelitis. So USG guided biopsy and aspiration was done. Then the pus CBNAT was negative. Patient was suspected to be late onset iris and hence was started on steroids. And we continued with the continuation phase of the CP of the AKT. Crazy pavement appearance was treated initially as fatty acid deficiency in view of chronic pancreatic insufficiency, and pancreatic supplements were added. Pediatric surgery reference was taken, and they had advised a conservative approach regards to the splenic abscess which was present in the CCT abdo, and they have called for follow-up after 6 weeks so that the pancreatitis matures, the pseudocyst matures. Then right elbow joint debridement was done because it was increasing in size gradually. We had also sent a culture for which the report is awaited. Now she is not complaining of any abdo pain. The oral intake of the child is also good. She is symptomatically relieved and is now planned for discharge with regular follow-up and review.
So what we understand from this is worked up very well. So the points what we understand from here is we are still dealing with a drug sensitive TB, right? So the initial investigations which were done in the outside hospital and even the investigations which are done now at BJ, they are all picking up drug sensitive TB, and even the culture is showing drug sensitive, right? So molecular is drug sensitive and the culture is drug sensitive. Okay. Still, in the interim period before she came to you, she was non-responsive. I mean, she went from pulmonary to disseminated. Now, since the time she has come to you, she's responding to therapy or she's not responding to therapy. Is she responding? She's responding, right?
Responding, weight gain is present. She's orally accepting feeds.
And her symptoms have also gone down.
Yes, symptoms have been resolved.
So there are two, three things in this. One, when we think that initial also the diagnosis was confirmed, why did the patient not respond to the therapy? Because we have a confirmed diagnosis of drug sensitive TB. So one, as we said, the important issue of compliance. Now, when we want to break this compliance, okay, into what could go wrong, okay, what we have seen in our clinical practice also, one is the patient not taking the drugs. That is one thing. Second, the patient taking the drugs, not taking the drugs in the dose which they advised to them. Like for example, if you see the NTP bands, we have 3P and 3E, then 2P.
Dr. Sushant, sorry for interruption. Whether the presenters have any slides to present for the
No, sir. This was the
then I can you just stop sharing and you can have the good interaction with all the students also. Please, Sushant, continue. Sorry for interruption.
No, it's okay. So the second thing is whether she is being taking. So most of the times what we see is the patients don't understand how to take the tablets. Okay, simple thing. Because now she is under your care in BJ and it's a supervised treatment which is being given, she is responding. We have come across cases where when the patient was taken asked to take 3P and 3E, the patient out of the pediatric tablets, the patient was taking one in the morning, one in the afternoon, one in the night. Okay, like this the drug is not going to work. The 3P has to go all together, the 3E has to go all together. If she's taking one, the therapeutic levels are not going to reach and the patient will not respond or the patient will worsen. Okay, so these are all minute things which we think, but they are important as far as when we think about response to therapy is concerned. Second thing is she taking tablets on empty stomach or after meals? Now that again is important. Now it is said in adults or even in pediatrics, in some patients it may affect or some patients it may not affect, but we don't know how it how the pharmacokinetics of the drug work in individual patient. But from our basic understanding of our pharmac, we know that INH and rifampicin has to be taken on empty stomach for better absorption, right? So always we say that 3P has to be taken half an hour before meals. E can be taken either empty stomach or after breakfast. That is okay. So this is the third thing what we must. So we are understanding why the patient did not respond, even though she was drug sensitive. So these are all the things. In spite of doing all these things, okay, if the patient did not respond, right? Matlab the compliance is good, the patient is taking tablets properly as advised, everything is okay. there are no adverse effects. Like for example, vomiting and all, everything is ruled out, and we are getting a repeated drug sensitive, then we should go ahead and think that in spite of doing everything, the drugs are not reaching the therapeutic level, right? Then there are multiple causes. We look for malabsorption, we look for any intake, because now this is a disseminated TB. And if we think of malabsorption, this is a candidate where we want to do a endoscopy and see whether the intestinal lining is okay, whether the drugs are reaching the circulation or not, right? That is one thing. And if we think that we are dealing with a low therapeutic level case, we need to send the drug levels. Okay, so first line and second line, both drug levels are now available. We see the drug levels. If they are low, then the protocol is different. Okay, how do we treat the low drug levels? Sometimes it may happen, and even in the drug levels, they do it, if you remember our pharmac days, they do it at baseline before taking the drug, then they do 2 hours after taking, 4 hours and 6 hours. Sometimes we have seen that the 2 hour level is okay, but the 4 and 6 hour level is low. That also can happen. So there are multiple things which can go wrong, which means the absorption is okay, but the drug is metabolized so fast into the body that the body is throwing out. Okay, if you remember the days, pharmac days, we have slow acelerators and fast accelerators as far as INH was concerned. So all these things come into play. So whenever we have such a case where we are sure that this is not a drug resistant TB, the first thing what we see is whether the drugs are reaching the site of organ, and these are all the things what we should think of. One thing what we have mentioned here is a NTM, right? Non-tuberculous mycobacteria. Now, considering, first of all, NTM is a little rare entity in pediatrics. That is one, as compared to adults. Second thing, the most common presentation of an NTM would not be systemic, but it would be localized. The commonly what they present is with lymph nodes. Either it could be cervical, which is most common, or mediastinal lymph nodes. And the third and the most important thing is, most of the times, I would not say 100%, but most of the times there is an underlying component of immunodeficiency when we think of NTMs. Either it could be HIV, that is acquired, or primary. So both we have ruled out. HIV is also negative. The child does not have primary immunodeficiency, right? But still, if we are thinking of NTM, the diagnosis is always on culture, right? So it cannot be the first diagnosis. So we need to tell the lab whenever we have sent a sample that yes, we are suspecting NTM. So kindly look into that, because NTMs require extended culture on solid medias. Okay, so like for example, TB, they will stop at 6 weeks, MTB. But MTB, they will go on incubating for 8 weeks or 12 weeks, and then they will give the result, and then they will do the typing. So that we have to tell, and we have to send at least 2 or 3 samples. Because if you see the protocols, they say out of the 3 samples which you send, at least 2 have to isolate the same organism, the NTM. Then we can say that this could be a causative organism in that particular patient. But again, you have to see the background. Is the child immunocompromised? Are there any risk factors the child was having? So if there was, the child was critically ill in the ICUs for a long time, if there were indwelling catheters, long indwelling catheters, then you can suspect NTM, because these are the risk factors where NTMs can go into the body. So NTM becomes a little lesser diagnosis. So these are the things what we should know now. Good that the patient is responding. So we assume that there was some problem into the intake of the drugs, right? Now, if the patient fails again, then what we do is we do a therapeutic levels. Even if the therapeutic levels are low, we need to go up on the doses. If the therapeutic levels are also normal and the patient is not responding, still, what it could be? This is the third possibility what we think of. Now therapeutic levels are also okay, we have done everything. Sometimes it happens that the levels are okay, but then still the patient is not responding. So what do we think of? Do we start MDR or we don't start MDR in this patient? So this is something known as a clinical MDR, right? So when we talk about TB, this is the last thing what we talk about. There is something known as heteroresistance. What do we mean by heteroresistance? Is there is a drug sensitive and drug resistant population both sitting into the same patient. Okay, and your drug sensitive, depending upon which is the prominent population, whether the DR population is more or DS population is more, the disease will behave that way. So disease, your DS population is responding to your HRZD, but the DR population is not responding. And probably at the time when you're taking the sample from anywhere, whether it is a joint or whether it is a spine or this thing, we are not getting that much bacteria which are growing. This can happen. Okay, so that is the last resort which we think of, and then we can start on clinical grounds, but not that the first thing. So that is a step by step thing what we think of in this case. That is known as a mixed or a heteroresistance.
Yeah, I think we'll have to end over here because we have overshooted the time. But there definitely presence of Dr. Sushant made the difference in understanding this type of the complicated tuberculosis. And certainly, I think there was a good case selection, absolutely. Even the presenters, the methodological, I would say, presentation, I'm sure that anybody is going to appreciate. And of course, we know that credit goes to the mentor, Dr. Pragati, and even even the fully worked up case that how we should uh, do it methodologically, and it becomes a good, I would say, learning for us, and we can help the patient in a better way. So certainly, I think all of us should learn. And with this thing, I would like to end over here. But as I would say, expert Dr. Sushant comments had made difference in understanding, which not only from the exam point of view, but in the practice also it is quite useful. Thank you very much to all of you. And over to you, Madam Dr. Aarti and Nehal.
Dr. Pragati, you want to add anything? Or your students have done the whole job for you? Okay, with your mentoring.
We have sent for NTM culture. So we have requested the microbiology department to do an NTM culture also for this child. And maybe because of the pancreatic associated insufficiency which she is having, maybe the drug levels she's not able to maintain.
Yes. Yes.
So in case she's not improving in future, maybe we'll have to plan a TDM levels for her in the future. So that will be the plan for this child.
So there are some TB where even there are studies and trials done where rifamycin doses have been increased to double, but they are all in the trial. They have not yet come in the national program. So this is another example of individualized treatment. So you cannot always have a national program thing. You will have to individualize this treatment after doing probably the levels. But I will congratulate you and both the students. They have worked very well and systematically presented with lot of involvement of the residents I can see. Okay, but still there is a little suspense about MOTO. And now please disclose it now, isn't it? Okay, because the person was answering very well all the questions and point to it. And I can see Dr. Sangeeta and Divya also active. And they're both looking after, like with Pragati, Dr. Sangeeta looks after the Center of Excellence for Pediatric TB at BJ. And a big thank you to Dr. Srinivasan sir and Dr. Baldev sir, that without their presence, I don't think so we get that touch of expertise which they have gained over the years. And a big thank you to Sushant. Keep coming on these
Ma'am.
Gurukul. Next
Yeah.
time we will bring you again. Okay. All right. And I think we can close it over here.
Baldev says, son, I am a SUN son, I am a star, small star.
Okay, I just want to tell all the other faculty and residents that you will find Srinivasan sir joining these sessions from the US. Sir, can you tell us what time it is over there?
It is now, of course, two. You have to add 2:30. No, 10:45, 42.
10,
10:45.
Yeah.
Okay, all right. You will see sir in all the other PG activities. So thank you very much, sir. And we
Thank
look
you.
forward
Thank
to
you for
having you.
informing me. I just noticed late. Yeah.
Yeah, I just sent you. I said I will have to wake you up if you are sleeping.
No, I was not sleeping. I was with my grandson, making him getting up and
Getting
this
up.
thing. Yeah.
All right, it makes a difference. So we'll close for today, Saturday, and a big thank you to all of you. Special thanks to Sushant. Thank you, everyone.
Thank you and
Thank
good
you.
night. Good
Good night.
night. Good night.
Good night.